Atrial fibrillation is an irregular heartbeat of the top chamber of the heart, of the atrium, and it affects millions of people throughout the world, and it's a cause of stroke and heart attacks and a lot of symptoms that cause patients with AFib to either feel fatigued, they can have chronic fatigue from that, they can feel palpitations that are very disturbing for the patients, and it can disrupt their normal lifestyle in that when they do have bouts of atrial fibrillation, they have to go to the hospital, the emergency room, they have to be anticoagulated or cardioverted, which means have the heart resynchronized back into sinus rhythm. So for patients that are affected with atrial fibrillation, it can be life-altering if they're very active, younger patients, or patients who can't be on medications for whatever reason. Either they have an allergy to the medication or a contraindication to the medication, or the anticoagulation, which is the mainstay of therapy for patients who are chronically in atrial fibrillation. And the anticoagulation really consists of Coumadin therapy, and that is to prevent stroke. And when the patients are in atrial fibrillation, clots can form within the left atrial appendage, most likely. They feel about 90% of the strokes related to AFib come from that appendage, and the Coumadin prevents them. There is lots of different ways to treat atrial fibrillation. You know, older patients who are asymptomatic from their AFib and they're well rate controlled can be treated just like that. And I think the vast majority of patients are treated with those therapies. Patients, though, that are symptomatic or are not responsive to the therapy for whatever reason, then need to do something else in addition to just the medication or medical therapy. There's a whole range of treatments from cardioversion or resynchronization of the heart rhythm, and the electrophysiologists, the EP cardiologists, have gotten adept at ablating the focus of atrial fibrillation within the heart. And that's a catheter-based therapy where they go up through the veins or arteries to enter the inside of the heart, and they can map the different focuses of atrial fibrillation and try and ablate those with either radiofrequency ablation, some energy source that can neutralize the tissue that is the trigger for the patient's atrial fibrillation. Recently, we've added surgical therapy to the treatment of atrial fibrillation. There's been many iterations of surgical therapy over the years, but most recently, a very exciting procedure has been developed around new technology to do those ablation procedures on the heart with a beating heart without using the heart-lung machine or doing a major incision, that are very, very effective at reestablishing sinus rhythm for those patients. So much more effective than catheter-based approaches, which may be 50% successful. Surgery for well-selected patients can be 80, 90+% successful in restoring sinus rhythm, alleviating those symptoms, getting the patients off their medications, and at the same time we remove that portion of the heart, the left atrial appendage, where clots can form. And I think that's a major advantage of the surgical therapy, and the fact now that we can do the operation, the standard operation, through now very, very small keyhole incisions in both chests under anesthesia, has really changed the way we're looking at using surgery to treat atrial fibrillation. The patients stay 1 or 2 days in the hospital. The recoveries have been remarkably shorter and much more well tolerated by the patients. So before, we used to either have to open the chest to do the operations through a sternotomy or large thoracotomies, and now we're able to do it through very, very small incisions, and the patients are finding that very well tolerated. Mini-maze is sort of a generic term that people have used to talk to atrial fibrillation surgery. The name maze procedure really originated back with the cut and sew surgical maze procedures done on the heart-lung machine by Dr. Cox, where they would actually create a maze pattern of the left atrium and right atrium of the heart by cutting it up into a maze and re-sewing it all back together. So you can see how that operation was a very, very large operation, took a long time, was difficult to do, there was a lot of blood loss and complications associated with that maze, creation of that maze out of that heart. So everywhere we cut, where the heart grew back together and scarred, would create that line of block. And we're now able to create those lines of block in that same tissue without physically dividing the tissue. By placing these energy sources across that tissue while the heart is still beating, we can accomplish the same operation. Mini maze was given to the operations where we were trying to make the operation smaller. Now we like to call it bilateral thoracoscopic pulmonary vein isolation with ligation of left atrial appendage. It's more anatomic and specific and speaks specifically to the procedure we're referencing, as opposed to mini maze, which can mean anything, any combination of maze patterns that are placed on the heart. Could be described as a maze, but you wouldn't know which one or what the patient had, so it's very nonspecific. It does lead to a lot of ambiguity as to what's going on. So, well, we've surgically treated many, many patients over the last 10 years here with a maze procedure. We used to do it concomitantly with valve surgery. Most typically, patients that have mitral regurgitation and need mitral valve surgery frequently have large left atrium that have become distended from that leaky valve. And we've been doing pretty much the same operation through a very large incision for quite a long time. I think in the last 6 months to a year, we've really embarked on keeping the heart beating throughout the procedure, using smaller incisions. We probably did 10 through bilateral mini thoracotomies, and now we've performed 3 totally thoracoscopic procedures in the last month. With really excellent results, early results. You know, the data takes years to accumulate. The goal is really to have reestablished sinus rhythm at 6 months from the surgery. So patients can have the procedure, still be in atrial fibrillation, even when they leave the hospital. Fortunately, ours have been in sinus rhythm, but that's not considered a failure of the procedure until the patient is 6 months out. They've had Holters and echoes and have been seen by their cardiologists. And we can document whether or not they've had episodes of AFib or whether or not they're in sinus rhythm. And at that time, because the inflammation around the heart takes several months to subside, and all that can generate atrial fibrillation, which is different. It's more just related to the procedure itself, not to their pre-existing condition of AFib. So it does take quite a few months to figure out which patients are going to be successfully treated with the procedure and then can be slowly taken off of medications. At that point, once we've established that it's safe to do so, you'd never want to stop those medications before you really knew that they were not going to flip back in and out of AFib, because that's when the strokes can occur. It's very exciting. You know, we're constantly learning about it. There are teams, really several throughout the country, a few in Europe, that are all sharing information and techniques. It's still going to really develop over the next 6 months to a year, but we're happy to be off to a very good start and with good results here at St. V's, and it's something we're looking towards as a really great operation we can offer our patients with AFib. So it's been exciting so far.